Hello, my friends. Thank you for joining me today. For those of you new to the channel, my name is Dr. Todd Fergus, and I am an interventional cardiologist based in Green Bay, Wisconsin. Today is part 3 in a 4-part series on coronary artery disease. The first and second episodes were posted earlier, and I'd encourage you to browse for those. For today, we will be talking about the variety of treatments for obstructive coronary disease, so let's get started. First of all, let's just review the difference between obstructive and non-obstructive coronary disease. So non-obstructive coronary disease, what I like to call lumps and bumps, is basically just mild atherosclerotic changes or mild plaque in the arteries. There may be a 20% narrowing, there might be a 40% narrowing, but nothing that's obstructing blood flow. So while this may not cause any symptoms, it may not actually limit the blood flow in the heart, it is a marker of elevated risk. So non-obstructive coronary disease needs to be treated aggressively, and that treatment usually consists of a combination of lifestyle modifications like diet, exercise, and smoking cessation, as well as some medications. So medications like a baby aspirin daily and a statin medication, the medications that we know will reduce the risk of future cardiovascular events like stroke, heart attack, or death. Now, on the contrary, we have obstructive coronary disease. So this is plaque buildup that's narrowing the artery by 70 or 80 or 90%, or actually obstructing blood flow to the heart. And this also, just like non-obstructive coronary disease, is a marker for elevated cardiovascular risk. But in addition to that, obstructive coronary disease can also cause symptoms of angina. And we've talked about this during prior episodes, that angina might be chest pain, chest tightness, chest burning, particularly when exerting oneself, or other less specific symptoms such as shortness of breath or fatigue. Obstructive coronary disease also needs to be treated aggressively with lifestyle and medications to prevent those cardiovascular events like stroke, heart attack, or death. But the anginal symptoms that come with obstructive coronary disease may need to be treated with other modalities as well. Now, what we're not talking about today is acute coronary syndromes. That would be unstable angina or heart attacks. These are a completely different discussion and will be discussed elsewhere. For today, we're talking about stable obstructive coronary disease. So let's talk about the options for therapy for angina. So there's 3 main options, and the first one is medical therapy. So medical therapy means using medications to treat the symptoms without actually fixing the blockages. The second option is PCI, or percutaneous coronary intervention, and that generally means a combination of angioplasty and or stents. And then the third option is CABG, or coronary artery bypass grafting. That's what's traditionally called open heart surgery or bypass surgery. So let's start with medical therapy first. Now, a lot of people raise an eyebrow when we say medical therapy because they're thinking, well, you're a doctor, you practice medicine. Isn't everything you do medical therapy? Well, yes, in a way, but when we talk about medical therapy, we're specifically talking about using medications or pills to treat the symptoms. There's primarily 4 different categories of anti-anginal drugs. The first one, in no particular order, is beta blockers. So beta blockers are medications like metoprolol, atenolol, carvedilol, and there's several more. And the second category is calcium channel blockers, and these are medications like diltiazem or verapamil or amlodipine. Then there's a medication in its own category called ranolazine. That's a relatively newer medication and tends to be more expensive, and yet is very effective. And then the fourth medication that many people have heard of is nitroglycerin. Now, nitrates come in a variety of different forms. It can be the classic sublingual tablet that you've heard of people putting under their tongue, but nitrates also come in a long-acting form that can be taken as a once-a-day pill, or even a patch that can be worn on the skin. All 4 of these categories of medications work in different ways and may be more or less effective in any given patient. Oftentimes we use a combination of 2 or 3 or even all 4 of these categories to manage a patient's angina. A second way to treat angina is by fixing the blockages with PCI, which stands for percutaneous coronary intervention. and this generally involves a combination of balloons and stents to open up the blockage. Now, balloons and stents are inserted through a catheter that's placed through an artery, usually either through the groin or through the wrist, and threaded up to the heart. First, we would place the stent within the lesion. Second, we would inflate the balloon to deploy the stent and expand the lesion. And then third, we would deflate the balloon, leaving the stent behind, and then the artery is open, allowing blood to flow freely. Now, we generally do this with one of two types of stents. There's the original, what we call bare metal stents. They're the non-drug coated stents, which work very well, but do have a chance of re-narrowing about 15 to 20% of the time. Or the second option, which we've had now for over 15 years, is drug-eluting stents or drug-coated stents. And that drug coating will prevent any scar tissue from forming on the stent. With drug-coated stents, the chance of in-stent restenosis is less than 5%. This is what it looks like in a real angiogram on a real patient. So you can see the arrow is pointing to the narrowing on the left-sided picture. And then once that stent goes in, that artery is fully opened so blood can flow through. And then the third option for treatment of angina is CABG, or coronary artery bypass grafting surgery. So with this surgery, we're typically using an arterial conduit, so either the left internal mammary artery, which is called the lima, or the right internal mammary artery, which is the rima, or even one of the radial arteries out of the wrist, and use these as a conduit or a bypass to reroute the blood flow around the blockage. Or we can use a vein graft, typically a saphenous vein graft that comes out of the leg, and plug one end of that vein into the aorta, plug the other end into the coronary artery downstream from the blockage, which effectively reroutes blood flow around that blockage and allows that blood to get into the heart muscle downstream. So those are the three options for treatment of angina: medical therapy, PCI, or CABG. How do we choose which one to use? Well, as you can imagine, it can get pretty complicated, but here are a few basic guidelines. Anti-anginal medications are oftentimes used in people with blockages in very small vessels, so vessels that are too small for our smallest stents. Our smallest stent is only 2 millimeters in diameter. Or sometimes patients have had every blockage in their artery that could be fixed has been fixed. They're still having angina, and then we're just stuck using medications. For coronary intervention, this is very effective in people with single or double vessel disease, so blockages in one or two of their coronary arteries, particularly when it's what we call anatomically favorable, so a pretty straight vessel, soft plaque. And in these patients where the anatomy is favorable, we oftentimes get a very durable result with coronary intervention. A lot of patients ask me, how long will these stents last? Well, in most situations, when the immediate result of the procedure is good, we can expect that stent to stay open forever, over 95% of the time. And then as far as bypass surgery is concerned, we are oftentimes using bypass surgery when the anatomy is not favorable for angioplasty or stents, and this is particularly true in patients who have diffuse multivessel disease, and diffuse means plaque or buildup or severe blockage along the entire path of the artery as opposed to one discrete blockage that could easily be fixed with a stent. When someone has more diffuse disease, the only way to stent that would be to use what's called a full metal jacket, or filling the entire artery with stents, and generally that's not favorable long term. Sometimes it's very straightforward to determine the best way to treat someone's blockages, whether it's with medical therapy versus PCI versus CABG, but sometimes it is a very complicated decision and requires an extensive discussion between the patient and his or her doctor. Well, thanks for listening to this discussion today. I hope you enjoyed it, and if you did, please hit the like button. Stay tuned for future episodes, including part 4 in this series on coronary artery disease. And in the meantime, stay active, eat healthy, and be well.